I bring you greetings from Calabar, the capital city of Cross River State. My assignment is to present Backache syndrome as a lecture to you all. Let me wish all of you a happy new year and a very successful outing in 2021 for those who are going for exams. My name is Nifrek Udomwa, Professor of Family Medicine and Chief Consultant Family Physician in the University of Calabar and University of Calabar Teaching Hospital, Calabar, Nigeria. I have a few disclosures and appreciation. I was told this is going to be a revision course, and therefore this is presumed in my presentation. I'm not teaching, I'm revising. I also have relied heavily on departmental presentations by Dr. Ta, and also had some inputs by my registrar, Dr. Aniete Tangu. Equally, I have relied heavily on reviews by Tyler Wheeler of WebMD. I really acknowledge and appreciate these sources. I will go through an introduction, anatomy of the back, classifications to causes of backache syndrome, the risk factors, management, beliefs concerning back pain, prevention, and I will publish the sources of the materials that I've used in compiling this lecture. Syndrome is known to be a combination of medical problems that show the existence of a particular disease or mental condition. And also, it's known to be a group of signs and symptoms that occur together and characterize a particular abnormality or condition. If you Google the word syndrome, you will see that it means a set of medical signs and symptoms which are correlated with each other and often associated with a particular disease or disorder. Therefore, backache syndrome is a disorder characterized by marked discomfort, sensation in the back. It's also acute or chronic pain located in the posterior region of the thorax, the lumbosacral region, or the adjacent region. Back pain could be either acute or chronic. It can as well be classified according to the area of the back, that is to say, either in the upper back, middle back, or lower back. Let's go through a brief anatomy of the back. The back part of the body is the region between the neck and the gluteal region. And you have the upper to middle back and the lower back. The upper and the middle back is the region below the cervical spine, which is the neck, and above the low back, which is the lumbar spine. The contents of the upper and middle back include the thoracic vertebrae, intervertebral disc, ligaments around the vertebra and the disc, spinal cord and nerves, muscles of the lower back, internal organs of the pelvis, skin covering the thoracic area. You can see clearly in the picture that I have managed to attach for you. The lower back starts below the rib cage and is also called the lumbar region. It contains the lumbar vertebrae, intervertebral disc, ligaments around the vertebrae and disc, spinal cord and nerves, muscles of the lower back, internal organs of the pelvis, and skin covering the lumbar region. Equally, this is shown in the picture. Now, what causes upper back pain? The most common cause is a simple musculoskeletal strain. Note that the spine is one long structure seen as three shorter structures. That's cervical spine, which is the neck, thoracic spine, upper middle back, and then the lumbar spine, which is the lower back. The thoracic spine moves very differently than the cervical and the lumbar spine, and is connected to the ribs and sternum, making it rigid and stable, so it's less prone to injury. This is the reason one can usually expect upper back pain to be related to muscles, not to the spine itself. Upper back pain is usually caused by soft tissue injuries, like sprains and strains or muscle tension caused by poor posture or looking downwards for a long period. This is the posture people take when they're looking at the handset in their hands. Poor posture and technique can combine to break havoc on the upper back. This is a common phenomenon now because of the advent of handsets. The common behaviors and activities that can cause upper back pain, like I've said, include poor posture and tense neck. Others could be twisting the body, whiplash, or other injuries, lifting improperly, overuse, repetitive movements, contact sports, carrying too heavy a load on the head, wearing overloaded backpack. Very common now to see people carry backpacks that are overloaded, far overloaded. Sympathize with children when you see them with their backpacks. Various forms of arthritis, inflammatory conditions, such as ankylosing spondylitis, fracture of a vertebra, osteoporosis, herniated disc, spinal stenosis, cancers that affect the spine also are implicated. Now, risk factors that can cause upper back pain. Lack of exercise can increase risk of upper back pain. During physical activity, the muscles in the belly and back support the spine. And therefore, when there is no physical activity or sedentariness, these muscles are weak and then will contribute to upper back pain. Excess weight. Since the spine supports the weight in the trunk, excess weight would stress the back. Goes without saying. And that's why the belly fat in particular is a problem. Much weight in the midsection can strain the soft tissues in the back. Some psychological conditions have been implicated. Experts are not sure why, but research has shown that one might be more likely to have back pain if one has depression and anxiety. People who have depression have worse back pain than people without depression. Smoking is also a risk factor. Smoking reduces blood flow to the spine, which prevents the back from getting the needed nutrients to stay healthy. Consequently, the spinal disc can degenerate because of that, which means that quitting smoking may help to restore some of the loss. Even when the disc will not degenerate adequately, quitting smoking reduces inflammation that causes back pain. The common symptoms one would have or expect during upper back pain injury. Those symptoms are usually associated with musculoskeletal strain. They include pain, tightness, stiffness, tenderness to touch, and headache. If related to the bones, nerves, or discs of the thoracic spine, symptoms may also include pain in the lower back, pain down the legs, incontinence, and numbness or weakness in the legs. How is the diagnosis made? This starts with a good history and a good patient-doctor interaction and conversation. Ask for a fall, inquire whether there was a car accident or any changes or increases in fitness seen. Then rank the pain on a scale of 0 to 10. Talk about how pain does or does not interfere with the activities of daily life. How it interferes with cooking, getting dressed, taking a bath. Then move on to do physical examination and see how the upper back pain affects movement. Ask the patient to sit, stand, reach out, flex, extend, and bend. Diagnosis can also be made using the X-ray, but this is controversial. It may not give much because we are talking about strain and sprain. That is why attention has shifted to MRIs and CT scans. Unlike X-ray, MRI or CT scan can give a picture of both the bone problems and soft tissue problems. It can reveal herniated discs or problems with muscles, nerves, ligaments, and bones. Then there are some blood tests that must be performed. We shall deal more extensively with this as I consider the lower back pain. But blood tests will reveal infections or any abnormalities that might point to diseases such as rheumatoid arthritis or certain types of cancer. Bone density test is also done, and this will determine whether there is or are at risk for osteoporosis. Then EMG can reveal compressed nerve, which may be caused by herniated disc or spinal stenosis. Common treatments that are available for the upper back quite a lot. And because there are so many treatment options, it means that there is no best option. In most cases, upper back pain is not a cause for worry at all. It can be uncomfortable, painful, and inconvenient. If pain develops suddenly and is severe, such as from an injury like a fall, and if pain and symptoms like weakness progressively worsen, medical attention is indicated. There are some few home remedies that are available. But let me warn that there are so many adverts and products that are shown on television about back pain or pain remedies. Few home remedies are useful. Gentle stretches, over-the-counter medications such as ibuprofen, naproxen, or acetaminophen. Ice can also be used to reduce pain and swelling. Heat can also be used to improve mobility and ease stiffness. Then one can do posture exercises, what is called the shin tuck. One sits in a chair with feet flat on the floor, shoulders relaxed and down. Now the chin is pulled inwards towards the neck. Then after the count of 5, it is relaxed. And this is repeated 10 times. There's also the shoulder blade squeeze. The hands are put on thigh, and this will make sure that the shoulder is kept down, roughly at the shin level. Then slowly, the shoulder blades are squeezed together After the count of 5, relaxed. This could be repeated 3 or 4 times. Then there is the upper back stretch. The right arm is raised to the shoulder level, directly in front. Then the arm of the elbow is bent and grasp that elbow with the left hand. Now gently pull it across the chest and hold for 20 seconds. This could be repeated 3 times on each side. So the combination of these posture exercises can be very, very useful as a remedy. Some prescription drugs, like I mentioned already, are very useful. In many cases, the anti-inflammatory muscle relaxants will do the trick to ease upper and middle back pain. Sometimes a very short duration upper pain relievers could be used, 7 to 10 days and not more. The patient may benefit from an anticonvulsant medicine. This works best for pain caused by nerve damage. Know that in a world where we practice that people don't believe in tablets much, a lot of people are cashing on this. Injections could be used, but may not solve the problem, but it will buy enough pain relief time to pursue other interventions like exercises and stretching. Physiotherapy is strongly recommended. Some people have applied acupuncture and chiropractic care. May it provide relief of upper back pain. Most cases of upper back pain resolve in 1 to 2 weeks without further treatment. Normal activity should resume gradually. So don't rush, let it be resumed gradually. Few types of surgery could be recommended. Although the idea of spine surgery can be very scary, it may be the most reliable way to get relief. Needing upper back surgery is very rare in upper back pain, and is rarely indicated for isolated upper back pain. Almost always due to an issue with spine itself, such as herniated disc, vertebral fracture, or deformity. When there are these 3 conditions, then surgery is highly indicated. Some surgeries will include kyphoplasty or vertebroplasty, spinal laminectomy or spinal decompression, microdiscectomy, and these are all options that are available by experts. What is the expected recovery from upper back pain? The source of treatment depends on cost. The success of treatment is purely dependent on the cause of the back pain. But there's one news here that I must give. Some people will never be pain-free. Therefore, for conditions that lead to chronic pain, like fibromyalgia or spinal stenosis, it is important to manage the expectation for the relief. The truth is that most chronic pain do not have a cure. One can only manage it. Which means that a combination of body therapy, like exercise and medicine, as well as mind therapy, will be very useful. And most musculoskeletal pain can get a lot better simply by moving painful muscles more and more. That's exercises. Most back pain gets better on its own, even if nothing is done apart from exercising patients. Let us get to the low back. Like I said, start below the rib cage and it's called the lumbar ridge. Low back pain and discomfort is the pain and discomfort limited below the lower margin of the 12 rib to the inferior gluteal folds with or without radiation to the lower extremities. Most common musculoskeletal condition and a common and vital reason for consultation with the family physician. One of the most common reasons for work absenteeism is low back pain, but there's a lifetime prevalence of 40%, affecting as much as 80% of people in the developed nations. Low back pain is thought to affect between 60 to 90% of the world adult population, who are between 30 to 50 years, and has a vital impact on the performance of daily tasks in people who are present with it. And it affects every sphere of an individual's life, self-perceived quality of life with biopsychosocial consequences. Low back pain is a public health problem due to the disability and significant economic costs associated with it. And that disability is the express combination of physical impairment and psychosocial factors. It's not only influenced by physical impairment, but also by the patient's beliefs and attitude, psychological distress, and type of occupation. In most cases, the presence of affective and psychosomatic elements may consequently become the chief focus of attention by the physician. It's the single leading cause of disability worldwide. Look at the Global Burden of Disease 2010. Distribution of low back pain among male and female is not very clear. Studies have reported higher incidence in males, others have reported increased incidence in females. And reportedly, it is more common with the age bracket of 40 to 80 years. The incidence peaks in the third decade of life with increasing prevalence until 60 to 65 years, then gradually declines. In industrialized nations, the point prevalence is about 32%, a one-year prevalence of 50%, and lifetime prevalence of 62%. In Africa, the point prevalence ranges from 10 to 59%, a one-year prevalence of 14 to 72%, and in Ibadan, Nigeria, prevalence of 46.8%. Almost the same, Sokoto, Nigeria, with 46%, with the highest prevalence of 69%. How do we classify causes of low back pain? This can be done according to etiology, mechanical or non-mechanical. It can also be done according to duration, as acute, less than 2 weeks, or subacute lasting between 2 to 12 weeks, or chronic lasting over 12 weeks. And then can also be classified according to the intensity, mild, moderate, and severe. Mechanical low back pain is commonly a non-specific form of low back pain. It's non-organic with no definite underlying etiology, and it's a result of structural problem in the lumbar spine, and it's a diagnosis of explosion when suspected or confirmed serious pathology have been ruled out, and it accounts for about 90% of low back pain. And it generally results from acute or cumulative traumatic events, also effects of mechanical stress on the lumbar spine from flexion, extension, rotation, twisting, heavy lifting, and abnormal static posture with resultant stress effects on the spinal and paraspinal structures. The lumbar position most at risk in producing such pain, its most common segment is L4 and L5. Mechanical low back pain is associated with occupations that involve forward flexion, rotation, twisting, and attempting to lift heavy objects with outstretched hands. Risks include prolonged sitting and standing, which causes strain on the spinal structures. The mechanism of mechanical low back pain include lumbar strain, which is due to stretching injury to the ligaments, tendons, muscles from overuse, improper use, or trauma. Another mechanism is nerve root irritation and compression. This is by mechanical impingement. Disease anywhere along the spinal nerves pathway, such as lumbar disease, which is called radiculopathy, or nerve inflammation due to viral infections such as shingles, and also lumbar disc damage, disc herniation, and disc rupture, causing a localized sciatica that radiates down the legs. Also, bone encroachment can cause it from movement, lumbar vertebrae into the adjacent spinal cord and compressing the nerves. Example, foraminal narrowing, spondylolithiasis, spinal stenosis, compressing nerve roots due to bony spurs or soft tissue or beading following trauma. The fourth is bone and joint conditions like congenital conditions like scoliosis, spinal bifida, degenerative conditions like disc degeneration, osteoarthritis of facet joints, and also trauma and injury, which is the lumbosacral compression fracture. I've tried here to show those kind of conditions that may lead to mechanical low back pain. What are the clinical features of mechanical low back pain? Usually of sudden onset, localized, and acute in nature. The pain may radiate to the thighs and legs beyond the knees and may be aggravated by waist movement, coughing, sneezing, straining, pontification, with or without anesthesia, indicate nerve root compression. Confirmed by increased radiation of the pain on lifting the lower limb. Sharp pain indicate nerve root compression. Bladder and bowel incontinence will be present in severe form of sciatica, frequently associated with a definite history of lifting, bending, or trauma. Now, the non-mechanical low back pain is due to an organic cause. It's not common. The causes include tumor, either primary tumor or metastatic from the prostate, breast, thyroid, myeloma, intrathecal tumor, osteocarcinoma. Can also be due to infections like septic ascites, osteomyelitis, TB, spine, brucellosis, and paraspinal abscess. The cause could also be inflammatory, sacroiliitis, osteoarthritis, spondyloarthropathies like ankylosing spondylolisthesis, and psoriatic arthritis. Richter's disease is also known because by it. This goes with pain and stiffness of the lower back, worse in the morning, relieved by exercise. Now, because there's some movement. It can also be metabolic, like Backache disease, osteomalacia, renal osteodystrophy, hyperthyroidism, osteoporotic vertebral collapse. It can also be a referred pain, like peptic ulcer pain could be referred to the back, disease of the pancreas, bowel, kidney, and also cause referred pain to the back, gynecological diseases, abdominal aortic aneurysm, retroperitoneal fibrosis, parasitic microfilaria, polymyalgia, rheumatic hip and urogenital diseases can also cause referred pain. Then the psychosomatic causes, the depression and somatization disorder. We are seeing that when we're considering the upper back. The clinical features are usually of insidious onset with prolonged duration, not so obviously influenced by posture or movement, and the systemic inquiry may give important clues to other causes. There are some risk factors. First group of risk factors are the non-modifiable risk factors, like increasing age, high parity, previous back injury, history of low back pain, and major spinal deformity like major scoliosis. Then the modifiable risk factors include occupational related risk factors. These are the most important risk factors. Low back pain results from prolonged standing or sitting incorrectly, twisting, bending, stooping, and lifting of heavy loads involving upward static posture. Most of the patients that we see will present, and if you take a careful history, you can always link to these risk factors. Another risk factor is overweight or obesity, which we are seeing in the upper back. When there is increase in weight, that will increase pressure on the lower back structures. It distorts the normal vertebral curvature, cause lumbar dislocation. Individuals that have obesity tend to live a sedentary lifestyle, has limited physical activity, has poor muscle flexibility, and weak muscles in the lower back region and thigh. Sedentary lifestyle with lack of physical activity is also a modifiable risk factor. We talked about tobacco smoking and then social factors. Stress and emotional tension is fully implicated. It's because this will tighten and contract the muscles, and this will lead to stiffness and pain in repetitive use of poorly stretched and toned muscles. Other factors include alcohol, wearing high heel shoes, walking with heavy equipment that vibrates. As if you look at the road, those who walk on the streets or the road with vibration equipment, at the end they'll come back or come down with low back pain. Some more causes like insomnia. One might expect a sore back to keep one up at night. But sleep problem can also lead to back pain or make it worse. A study found 1.5 times more likely chance to get back pain if one has insomnia. Researchers aren't really sure exactly why, but insomnia can make one more sensitive to pain. Stress can play a part too. The way one walks too is implicated. Foot pain, bad feet, or other problems can throw up one's stride. This can lead to strain on other parts of the body. Example, the backache kicks in when one stands up or starts to walk. Video gaming is very common now, and then gamers tend to spend lots of time seated with their heads tilted forward and their shoulders slumped. Poor posture and hours of sitting can lead to muscle strain and stiffness. Scar nerves is implicated too. Scar tissue grows after an injury or surgery around the nerves in the back. This helps the nerves to heal. During movement, the scar can tuck onto sensitive areas. Scarring also can block blood supply to the nerve. Also, women who have had cesarean delivery have been implicated to have low back pain. A study found that women who gave birth by cesarean section with epidural anesthesia were more likely to have lower back pain later. Labor can put the body into strained positions. Epidural anesthesia cancels pain, so one could lie for a long time in an upward posture but without feeling it, and that can damage the back and lead to pain. Limiting activity for a while after a serious delivery can weaken abdominal muscles, which is another cause of back pain. Too tight trousers or knickers. A study of men who faced wall slacks that fit, then switched to smaller sizes, found the snug pants changed their movement and posture. Tight clothing leads to awkward movements in the lower spine and pelvis. It can make one slump when sitting. This weakens the muscles that keep the spine in line. Urinary tract infections is equally implicated. UTIs can cause back pain, but usually it's fever, chills, or nausea. Bulky wallets in the pocket is implicated. This strains the muscles in the pocket, the buttocks. Also strains the sciatic nerve and can trigger lower back pain. Therefore, slim, uncluttered wallets in the front pocket can solve the problem. Excessive wearing of slippers. As one shuffles, the feet strike the ground flat with little cushioning to absorb the impact. This changes the natural strength and hurts the feet. The stress and pain can move up into the legs, hips, and lower back. How is it managed? Some clinical evaluation to achieve the following goal. Determine the source of pain, identify those with severe underlying disorder, identify any contributing factors, assess the patient's illness experience, assess the degree of pain and functional limitation, then prepare an appropriate treatment plan to ensure that the patient is active as soon as possible to return to work. Good history is important. Review the nature of the pain, onset, severity, location, duration, aggravating and relieving factors, mechanism of injury and its relation to onset of pain, history to reveal neurological symptoms, history to reveal symptoms indicative of systemic disease or infection, screen psychosocial risk factors, family history of spinal disease, evaluate for trauma, lifestyle, previous history, explore the illness experience, past medical and social history and drug history, and then review the system. There are some red and yellow flags. A history of, in order to guide the treatment plan. Rule out more serious pathology by screening the red flags, and rule out risk for chronic disability by screening for yellow flags. What are the red flags? This involves symptoms or findings that should lead to prompt medical intervention and possible referral to another subspecialty. Without red flags, treatment is conservative. Examples of such red flags are less than 20 years or greater than 50 years old, low back pain for the first time, high impact trauma. Pain is constant and getting worse at night and at morning, awakening without relief. Fever, weight loss, fatigue can indicate malignancy. Neurological features such as distal weakness and numbness, sudden anesthesia or bowel and bladder incontinence, previous cancer history, immune system deficiency, steroid use, and IV drug use. The yellow flags are psychosocial prognostic factors that are likely to increase the risk of one with acute lower pain, developing prolonged pain and disability and failure to return to work. It suggests high need for intensive treatment and possibly referral. Explore the signs of drug addiction, as when patients keep seeking pain medications and when there is history of multiple doctor visits, including loss of prescriptions. Examples of the yellow flags we believe that the pain is harmful or potentially severely disabling without recovery. There's always fear avoidance behavior and reduced activity. Depressive symptoms like tendency to low mood and withdrawal from social interaction. Expectation of passive treatment rather than a belief that active participation will help. Poor job satisfaction with history of time off. Overprotective families, the lack of support. And then work-related injuries still in litigation. And then presentations not consistent with pain severity. These are all the examples used in the history. Management starts with physical examination. Ensure patient privacy. Begin by asking the patient to walk across the consulting room, turn around and come back while observing the gait. Examination should be done in 3 positions: standing, sitting, and supine positions. Then do inspection in a standing and sitting position from back to front. Observe the posture on sitting position. Visual inspection of back for obvious normal swelling, deformities, and so on. Then palpate the spine and soft tissues for tenderness and swelling. Then also motion is examined. Examine the range of motion, and this will include flexion, extension, lateral bending, and rotation. Then also there must be neurological examination to assess sensation over the back and extremities, muscle tone and power, deep tendon reflexes. Some special tests are there. One, for nerve root impingement syndrome. This is done with patient lying supine. And do a straight leg raising test, which we all know. Passive lifting of the leg with extended lead will produce pain that radiates down the posterior or lateral part of the leg and usually into the foot. And this will assess presence of reticulopathy. If there is large dissemination, the opposite leg produces a positive response. Then it could be the lancet test. Dorsiflexion of the foot during straight leg raising will exacerbate the symptoms. Modified Scoper's test. The mark is made approximately at the level of L5. Another mark is placed 10 cm above this mark. The patient is asked to bend forward as far as possible, and the distance between 2 marks measured. The distance should now measure more than 15 cm. If less than 15 cm, it suggests restricted lumbar spine flexion. There are some investigations. Within 6 weeks, most patients with low back pain usually recover fully or partially following conservative treatment. Imaging studies are usually recommended within 4 weeks of acute pain onset, except in suspected case of infection, malignancy, or neurological deficit. Plain X-ray should be initial imaging study. It is cost-effective and readily available. Remember, I had talked about X-ray. This should be the initial imaging study. Don't jump into doing MRI or CT scan. Now, CT scan is preferred, however, because it will detect subtle abnormalities of the bony architecture of the spine and sacroiliac area when plain X-ray is normal. And also, CT scan is diagnosis of fractures, tumors, hidden dissociation. Here, one is saying where there is capability and there is availability CT scan and MRI are better done. MRI is best in identifying spinal pathology like infections, lesions, than a CT scan. It is the imaging tool of choice for spinal nerve structures. Myelography could be done to show site of tumor, dissemination, and entrapment. It can also be used when MRI is contraindicated. Can also be done. Another one that can also be done is bone scintigraphy for detecting presence and extent of metastasis. EMG and nerve conduction studies can also be done to confirm location of nerve root lesions. There are very many ancillary tests that could be done. Specific tests should be ordered as suspicion of a non-mechanical cause of the pain. It ranges from full blood count, biochemistry profile, acid and alkaline phosphatase, PSA, benzoate protein, blood culture, mantle test, chest X-ray, and Puto for acid fast vascular. There are very many modalities of treatment, and the treatment is classified into two groups, non-pharmacological and pharmacological. The non-pharmacological treatment, I've already mentioned a few of them, like massage, relaxation therapy, yoga, breathing exercise therapy, and the rest of them. While the pharmacological treatment includes use of simple medication like acetaminophen, NSAIDs, narcotics like codeine and tramadol. Said that muscle relaxants could also be used for muscle spasm. DCAs could also be used in neuropathic pain, especially when depression is present. Also useful in chronic back pain, example, amitriptyline. Calcium supplements are available and could be added to post-menopausal women due to osteoporosis. A lot of these calcium supplements are available in the market. Some interventional treatments are available. These include both diagnostic and therapeutic procedures done by a pain specialist. And this could be epidural steroid injection, selective joint injection, nerve ablation, dystonic facet, and nerve block therapeutic rhizotomies. So many other treatment options are available, like physiotherapy, and then surgery for well-selected patients. And such surgery will be discectomy and microdiscectomy. There are some beliefs about low back pain: etiology, fear of the pain, self-efficacy, personal characteristics, previous experiences, cultural available information, stepping on a charm, spiritual cleansing, and so on and so on. These are all beliefs that make management of low back pain very difficult. People really believe that low back pain could be handled like that in the hospital. It's always a belief, especially in our own local environment. Always available charms. Someone has sent the spirit to break his back, so it will be useless. And low back pain affects the man's power. That is worse. So how could low back pain be prevented? This requires avoidance of risk factors. And for the non-mechanical low back pain, requires early detection and treatment of the cause. There is no sure way to prevent back pain at one ages, but there are steps one can take to lower the risk. The preventive measures will include lifestyle modification, which would include health education on cessation of smoking, weight reduction, with dietary counseling, regular exercise to condition the heart and back muscles, and also keep the back strong and healthy. Lift with the legs, not with the back. See, the picture on the left shows wrong method of lifting. The picture on the right shows the right method of lifting. Fortunately, most people use the left posture when lifting. Now, make sure workstation position isn't contributing to the pain. Workers at risk should be educated on need to modify their posture during occupational activities by preventing excessive flexion and extension motion, encouraging interaction of prolonged sitting, standing, and walk around vertically at workplace. Use of ergonomically designed chairs with back support at workplace. This will show the normal 3 cups at the back. And most of those chairs show the normal 3 cups at the back. Then health education on proper standing, sitting, lying, and moving, and lifting objects. Also, wearing of low heel shoes to prevent tension on the back. Then also emotional stress, creating a balance between work, family, and leisure to reduce emotional tension. Patients should be advised on creating time to be alone, to relax and rest. Meditation, breathing exercise can also be beneficial in relieving muscle tension. These are the sources that I used in preparing this lecture, which I had already acknowledged contributors. Thank you for giving me that listening. Thank you.